All right. Hi, everyone, and welcome to today's lecture at the Texas Epidemic Public Health Institution Infection Prevention and Control Series, along with partnership with the P2R Consortium. This lecture is titled Infection Prevention 308, and we're going to be talking about emerging infectious pathogens. This lecture is just a brief overview of the 2024 Marburg outbreak in Rwanda, and along that we will also be talking about dengue and H5N1 activity here in the United States. If you're new to this lecture series, these lectures are recorded and slides are made available approximately 1 week after the lecture has been given. So within about a week, you should receive an email with a link to today's recording along with the slide deck. So my name is Dr. Kayla Rush. I'm an infection prevention practitioner that has experience in acute care, long-term care, and skilled nursing facility across the United States. And I also hold a PhD in epidemiology with a focus on infection prevention, control, education, and training, along with orientation practices. And I work at the Texas Epidemic Public Health Institute, which is housed at UT Health Houston School of Public Health in Houston, Texas, with its main goals to help improve resiliency and capacity to help Texas respond to future infectious disease outbreaks. Today's lecture has been approved for multiple continuing education hours, and at the end of the presentation, there is a detailed slide that takes you step by step of what you need to do to obtain continuing education hours. So to complete and obtain continuing education hours, you need to attend the activity 100%, complete the post-test or the learning activity and score on at least an 80%, and then also complete the post-survey evaluation of today's lecture. This lecture has been approved for continuing medical education hours, or CMEs, along with CNEs for nursing continuing professional development, along with other continuing education hours such as your CHES, your CPH, and your RS, along with continuing education hours for APIC holders and CIC holders through the Certification Board of Infection Control. One disclosure, I am a consultant for BD. However, this lecture will not endorse or promote any type of products and specifically with that company. This lecture doesn't endorse any commercial products. And then today's learning objectives will, as I mentioned before, will be to discuss the 2024 Rwanda Marburg outbreak, and then we're going to go into discussing and kind of getting a current state of event for dengue and H5N1 here in the United States. After today's lecture, we'll go into a learning activity, which will have everyone scan the QR code. It is a 10-question multiple choice learning activity that will go quick, and then we'll provide some announcements and then open the floor for questions. So I ask you to keep all questions until the end, and then we'll open it up for questions after the learning activity and announcements. And again, if you joined a little late, today's lecture is recorded. And within approximately a week or so from today, you will receive an email with a link to the recording along with the slide deck. So let's begin. So we're first going to give an overview and kind of talk about the 2024 Rwanda outbreak that happened about a year ago. So first, let's talk about the virus, the Marburg virus. It is a vivovoid genus. It is a single-stranded negative case. It is closely related to Ebola, and its zoonotic reservoir, or the animal that really is the vector and kind of transports the virus, is the Egyptian fruit bats. And we see a lot of spillover of this virus due to human environment interaction. So that is when humans are in the environment and they're having direct contact with secretions of bats is specifically their feces or their saliva in the areas, and then that is specifically in caves and trees and mines where usually the bats live. And then we also have human to human transmission. So when a human is infected, it can spread to another human, and that is direct contact with bodily fluids. So any saliva, blood, or any tissues of infected person. And that can also be contaminated with different surfaces, needles, or any type of medical equipment. So far, there has been no documentation of airborne spread of this virus, but very much highly transmissible through contact with bloody secretions or other tissues from the infected patient. So individuals that present with their first signs and symptoms, it's going to be a sudden very high fever, severe headache, muscle aches, vomiting, diarrhea, and this is the internal and external bleeding. So a lot of hemorrhaging, a lot of blood secretions. And as I mentioned just before, this is a highly transmissible through those blood secretions. The incubation period is usually between 2 and 21 days. So you have a longer incubation period where the vial, where you can get exposed and therefore then show signs and symptoms later in that 21-day period. And it can have severity also leads to the mortality. So there's from previous historical outbreaks, the mortality rate of this pathogen has ranged from 23% to 90%, depending on the outbreak and kind of what happened with that specific population. And then also with the infection prevention and control measures that were initiated during that time. This is a highly virulent pathogen, especially when there are limited healthcare infrastructure. So when you do not have infection prevention control plans, emergency preparedness readiness plans, we're kind of seeing a higher spread of this pathogen, usually due to non-compliance or limited resources of infection prevention. Maybe they don't have donning and doffing of PPE, very limited PPE if there's any reusing of any type of equipment during that time. The way that we diagnose this, our gold standard is with our PCR events. So we're making sure that we're collecting samples and setting it. You can also do an ELISA assay and then also a virus isolation. Any type of lab testing will be done in a BSL level 4 lab. So those are the labs where there is negative pressure, individuals are working under their hood, and then they're also in the specific biosuits, kind of the space suit, and they're on the track lines with their helmets to have specific oxygen to make sure that they are protected when handling and doing laboratory assays with this. So it's a very high risk pathogen. It's very virulent. It has high consequences. And so we need a very high level facility to be able to work with this pathogen safely for our laboratory personnel. The treatment, there's no specific approved treatment. It's very much supportive care, which is your IV fluids, making sure that their chemistries and their electrolyte balances are appropriate, along with providing oxygen. Due to the internal and external bleeding of being very hemorrhagic, we'll also be doing blood and platelets transfusions, and then they're also at risk for secondary infections as well. There are some investigational therapies that are used, are monoclonal antibodies and some antivirals. Remdesivir is one that we've been giving to, and right now there is an experimental vaccine under development specifically looking at this. It's a one dose. It's in preclinical trials, and hopefully we can see, can go through more trials and that we can continue to see the progression of a vaccine. As I mentioned, it is highly pathogenic, highly virulent, and highly transmissible. So we want to make sure that we're using our top level of PPE. So making sure that you're double gloved, You are wearing a whole gown, the overalls, coveralls, the whole suit, have eye protection, goggles, N95 or higher, especially if you are doing any aerosol journalizing procedures or AGPs. So if you're venting a patient, if you're doing any type of respiratory procedure, scoping them, making sure everyone in the room has a 95, and this would be here in Texas, this would be an immediate reportable to public health. This is an immediate phone call to them, and then we're talking about location and transfer of the patient. Most likely your facility is not set up to handle this patient, and our designated Region 6 facilities is down at UTMB in Galveston, Texas, that you would set up transport for these patients. They have a specific unit that they deal with high consequence pathogens, that they have the type of infrastructure such as the physicians training and engineering controls to really deal with these high pathogens of consequences. So you would coordinate with them to make sure that they're aware of the patients, transferring them so that they can get appropriate care. And then if somehow you would have this patient, you always, since it is a very high pathogenic, high consequence, virulent pathogens, you need a single room, dedicated bathroom with these types of individuals. It's going to be single use. The waste category is also going to be a class A, so you will need to handle it, double bag it, incinerate it, and you will not be able to use any reusable equipment on these patients. They will need to be in airborne isolation rooms with negative pressure, with the appropriate air exchange. You will keep door closed at all time, and then you will limit personnel entry to that, visitors. With your donning and doffing PPE during this high pathogen of consequence, it would be best practice to have a spotter, so someone watching you don and doff, and you would also set up zones of where you put on clean PPE, where you're taking off or doffing contaminated PPE to make sure that you are not cross-contaminating yourself or others in the area with it. So you want that direct observation with a spotter for that. For patient transport, as I mentioned before, that most likely that you would transport this individual down to UTMB in Galveston, and then also in your facility, limited patient transport with these high pathogens of consequences with Marburg, with Ebola, with any hemorrhagic fever viruses. You want to limit the movement and transport outside of the room. So only if it's absolutely necessary. You want to make sure everyone is covered in PPE. So if they come into the smallest droplet of body fluid, that they are protected. They will need to be in PPE. Even transporting this patient, you will be in PPE the whole time, which I know that kind of goes against our usual transportation methods, that we do not wear our gowns and full PPE in the transporting, and you will also map off and coordinate an area and a pathway of transporting this patient. So if this patient would come into your ER, you would hold it in the room and then map out how you are going to escort them out to the ambulance to be transferred down to UTMB, making sure everyone is wearing the right PPE and 95, and that no one is coming through that pathway when you're transporting it. So coordinating all of that in the beginning. And then making sure that you're disinfecting everything with an appropriate level L, list L EPA registered disinfected. And then, as I mentioned, it's going to be everything that goes into that. It's going to be a category A infectious waste. And then you are going to follow your strict laundry sharps. And if you are using reusable medical devices, but I would recommend going back to your policy and eliminating any type of reusable medical device for this patient, and going to single use everything when dealing with these high pathogens of consequences. So now that we kind of have a background of what Marburg is, let's get into talk about the Marburg outbreak that occurred last September into the winter months in Rwanda. So this was the first ever outbreak in Rwanda, and it was officially started on September 27th in the Kigali health facilities, and you can see in the cluster location on the map here. So it started on September 27th. And then as October 19th came around, there were 66 confirmed cases and then 15 deaths, which created a case fatality of 23%. However, there was 51 recoveries. And then the outbreak kind of continued on to the last confirmed case of October 30th, was the last confirmed initial case. And then the last patient was discharged from the facility from number 9. So this is about a 6-week period of time where we started seeing cases. And that kind of goes into our epi curve and outbreak, that we first start seeing cases you can see the 26 cases in the beginning of that first week on the 27th of September. And then we saw 24 cases the next week, finding another jump. And then with the couple weeks later in October, the 7th through the 13th of October, going into 12 cases, and then going down to the end of November, just having a case, 2 cases, 1 case, and then following it with no cases. So you see a high case count of a new prevalence in the first couple of weeks, with an incidence kind of waning through that, or prevalence waning throughout the time period. And when we look at most of those case counts, a lot of them, 78% of the case counts were healthcare workers, specifically within a couple of the regions specifically. And then looking at that, more of the epi data, that of those cases, about 68% were male, and then with 46% aging between 30 and 39 years of age. So when they started looking and deploying their outbreak investigation team, one thing that they wanted to look at is genomic analysis, of looking at, is this one specific strain or these multiple strains. So that's when genomic analysis really comes and plays a great part of really identifying, is this one outbreak with the same strain, or is this multiple strains within different kind of mini cluster events of outbreaks. So they determined with their genetic sequencing that this was a single zoonotic spillover. So this is one specific strain of Marburg that was in the community, and it was specifically from their Egyptian fruit bats, which was in a mining tunnel nearing this location. So they identified the source of the infection, and then they use that to look at serological evidence and contact tracing to really support how this was being transmitted to individuals. And if this was more from bats to humans, or from an initial index case of one human from a bat and then more human to human. So they found that it was a mixture of both, from bats to humans and then humans to human spread. And then this is a lovely graphic from the case report that the Rwanda kind of did. There's a link in the end of the presentation that looks at it, and you can look at this beautiful contact tracing where you can see the index or the start patient, so patient 1 or patient 0, that we refer to, and then how that a contact and then went to spread, along with its fatality rate of these individuals that you see. So with the response, not only did the Rwanda government quickly identify this, as you saw, it's a 6-week period of time, but they also had international support, specifically from the WHO and international partners as well, that really helped deploy the contact tracing to make sure that we identified what genomic sequencing, if this is one virus, one strain, or multiple strains in a cluster of events, and then also enhancing and providing more resources for diagnostic testing. So making sure that we had live surprise technicians, they were handling the fluids and testing appropriately, and that they didn't have risk of exposure with testing in the lab, and then also help to ramp up infection prevention and control measures. So national cascading training efforts, So putting more effort into not only local but national training efforts for surveillance, case management, IPC, WASH, which is a WHO project, along with making sure that there was clear communication within the community of what was going on and what was going on in the health systems as well. So community engagement and risk communication was key to make sure that, there was not fear, there was not ensuing panic, that we were being transparent of what was going on, what was being done, how people can remain safe, and what they can do to help keep them safe at home. It also helped. There was also support for deployment of investigational vaccines and remdesivir, so for treatment for these individuals to help recover. And then they also helped with supply chains and readiness for clinical trials. And the U.S. did play a part of this and provided aid during this time. So then on December 20th, the Rwanda government officially declared this outbreak ceased. So from September 26th to December 2020, the outbreak was concluded with no new cases seen at that time, which was aligned with WHO protocol. So this outbreak was the third largest Marburg outbreak globally, but it also had the lowest case fatality, which was really excellent, due to kind of this readiness of communication, going into infection prevention, education, providing laboratory supplies, sequencing, a national level of surveillance and contact tracing to really help make sure that we identified the spread, where it was coming from, and then mitigated the transmission. So as I mentioned, this was the third largest outbreak, and you can see here historically. So this is the third largest outbreak historically. However, in the last 20 years, this is the largest outbreak. And you can see with its higher case count, our mortality rate was lower due to identifying and collaboration of different partners to really help in this need with this pathogen of incidence. Here in the United States, you can see that there was one infection in 2008, which it is travel associated. So the individual was in Uganda and then came to Colorado, and then they did have signs and symptoms, was treated and recovered. And the main lessons learned from this group was that early detection and rapid isolation was key. Healthcare worker safety must be optimized, especially with early IPC reinforcement, education, interagency collaboration really helped reduce the spread, getting out communication, providing resources, and just huge local and national and international collaboration to really was essential for outbreak containment, along with genome sequencing, contact tracing, and with going into that, talking about risk communication and public and community engagement to really help foster that level of trust in the public, and making sure that everyone knew what was going on and what the government was doing to contain this type of infection. And this kind of spillover and outbreak really goes into the One Health model, which is looking at how human, animal, and environmental health really interact. So we're starting to see more of these types of events, that we have a zoonotic infection that really starts in an animal population, but then humans go into that environment of the animal or touch the animal and then become symptomatic sick, and then we have human-to-human transmission. So that's the end of Marburg, and now we're going to go into dengue in the United States. So dengue is a flavivirus. It has 4 specific different serotypes, 1 through 4. The transmission vector of how we get these infections are specifically from mosquitoes, looking at the Aedes aegypti and Aedes albopicus mosquitoes. And the good thing is that if you are infected with one serotype, you have lifelong infection. However, due to antibody-dependent enhancement, that causes you increased risk of severity for a second infection. So antibody-dependent enhancement is when the immune system ramps up antibody production from one serotype, but then when a second serotype becomes infected, it's a completely naive infection and your immune system kind of goes into overdrive. So you'll have a more severe reaction immunology wise to really ramp up. So that's why usually that second infection or that second serotype infection that you get, if it is a different serotype, will be more severe, or there's an increased risk of it being more severe because of this. Signs and symptoms for this virus include sudden high fever, especially headache, joint pain, rash, nausea, vomiting, and mild bleeding. Incubation period is usually 4 to 10 days from the mosquito bites, and it can, as I just mentioned, lead to severe dengue where you have plasma leakage, severe bleeding, organ impairment, and it can be fatal without supportive treatment. How we diagnose this, and again, is using antibody detection, using PCR, and there's no specific treatment. It is more supportive care, making sure that we have fluid, pain relievers, so our acetaminophen or Tylenol, and we want to avoid NSAIDs because NSAIDs put you at a risk of bleeding, and there's already a risk with this infection with bleeding, so you want to make sure that you're not giving or taking NSAIDs, you're taking acetaminophen or Tylenol-based products. Since this transmission is specifically from a vector to a person and there's no person-to-person transmission, how we handle these patients in the healthcare settings is standard precaution. So there's no specific isolation requirements. There's no specific patient population. However, we want to use EPA grade infections list Q. This is a notifiable condition to the Department of Health in Texas. However, just because of the original infection, they might be more symptomatic with respiratory illness. So then you might want to think about individual placement. Are they coughing? Are they sneezing? Are they producing droplets? So maybe putting them on respiratory precautions or droplet isolation basis on how patient is presenting at that time might require that single patient room. And here's just kind of some data. I pulled this earlier from this week of dengue in the United States. So in the United States and territories of the United States, we've had over 2,800 cases in 47 different jurisdictions. So you can see here, we are seeing these cases more in the United States. And then when we break it down to locally acquired, we are starting to see cases in Florida, along with the Virgin Islands and Puerto Rico with the highest case count specifically in those areas. And we're seeing it within 4 different jurisdictions in the United States. And then when we look at travel associated, so that's when someone has gone to an endemic region of dengue and then coming back to the United States or to their state specifically, and they're starting to become symptomatic, we are starting to see cases. In Texas, we've had 28 cases this year specifically, and you can see that we've had for a total case count of 518 throughout the United States and territories, and it has been in 45 different regions. So we're starting to see this here in the United States as more kind of travel related. Again, it is a Texas notifiable condition. It is with 1 week. So also when you're having these patients, it goes into flu-like symptoms. They kind of present that way. So if they come up negative on flu panels or your respiratory panels, maybe thinking about an aerovirus or malaria too, we're starting to see a couple cases pop up here and there. So after you've ruled out your regular or kind of your standard workup for respiratory and flu-like symptoms, maybe start thinking of out of the box of, maybe it could be dengue, maybe it could be chikungunya, maybe it could be malaria too, and expanding the files if everything's coming up negative on these patients. And the best way for prevention, since this is a vector transmitted disease, is really having good mosquito control and personal protection. So making sure that you are having wearing appropriate attire when you're outside, making sure that you're wearing repellent, appropriate clothing, and then in Texas, we do have our mosquito control program, and at the local level too. So if you're curious about what's going on in specific your counties, I would recommend you reaching out to your specific county to see what's going on in their mosquito control or vector control department within your group of public health to see if it's popping up specifically in your county. And again, kind of this is more of a One Health model for the specific type of pathogen of really looking at the relationship of environment, animal, and human. So most of the time when we see patients with these infections and we're starting to see them within the United States, we are getting it transmitted from an insect, specifically a mosquito bite, and then we're becoming symptomatic for that. So we're not also seeing it with humans, but we can also be seeing it in our animals too. So making sure that we have good prevention measures for our animals as well, and then environmental controls of making sure that you don't have any standing water, wearing the appropriate PPE. And that kind of goes into this lovely graphic that DSHS, the Department of Health of Texas, has put out that you can download. And there's a link to the PDF in the resource section of this presentation that really shows ways that you can prevent, making sure that you do not have any standing water, tires, bird baths, nothing collecting water. And then it goes kind of more into the cycle of how this spreads, but making sure no standing water and that we're wearing appropriate clothing and repellent when we're in very mosquito endemic areas. And currently, globally, there are 2 vaccines that are being developed right now. One is for previously infected individuals. So they have already been infected to one of those 4 serotypes that I mentioned. This one's still in development. And the reason why that they restrict it is to making sure that they are not, without previous infection, they're at an increased risk of severe dengue based on that antibiotic-dependent enhancement that I briefly talked about. And then there is another global vaccine that is recommended in other countries that they're working on since the spread of this is we're just starting to see it here in the United States. As you can see, our case counts, but globally this is in more tropical areas, and it is endemic in other parts in countries of the world too. So there is an additional vaccine and it's under clinical trials in Thailand looking at this, looking at sort of immunity for this. So now we're going to go into kind of an H5N1 in the United States, which this is our subtype of our influenza virus, which we're kind of starting respiratory season here in the United States. It's a negative sense segmented RNA, and our main zoonotic reservoir is our birds, our sheep, our cattle, kind of all of our farming livestock. And this has been another spillover event. So we're getting it from humans are getting infected from exposure to infected animals. So either coming in direct contact with infected birds, their secretions, any contaminated water. And so far, there is no human-to-human transmission that has been reported. Thus, signs and symptoms for this is typical influenza-like symptoms with red eyes, irritation, cough, sore throat. The biggest factor or presenting symptoms has been conjunctivitis in the United States. Fever may or may not be present, and just like any type of influenza, it can go from mild to the other category of moderate to severe. So having a very high temperature, which can lead to seizures, unconscious, and it could potentially lead to mortality. So some in the more severe infections, it can lead to complications with pneumonia, respiratory failure, kidney injury, along with a septic event. There's also, for this virus, there is an incubation period of from 2 to 7 days, but it also can range to 1 to 10. Usually for influenza, we in healthcare settings, you should be monitoring for 10 days for signs and symptoms, and then putting isolation accordingly, depending on when they're symptomatic, and then keeping it for 10 days. Diagnostic ways is looking at our PCR. You can also do a culture. The rapid test, so the rapid or point of care testing, such as COVID, RSV, and influenza A and B, the rapid test that is done at point of care, that does not produce a serotype. So you cannot specifically say that it's serotype H5N1, but it's positive for influenza B, influenza A. So making sure that you're aware of that. If you are suspicious or a patient tests positive for influenza A, and then in kind of that outpatient area, either in an urgent care, in an ER, but then becomes more moderate to severe, making sure, you're thinking about and advocating for serology or PCR detection on that to see if you can do your serotype if it's in fact H5N1. Treatment for them is just like our regular flu. So we're doing Tamiflu is kind of the main one. It's usually most effective within 48 hours, but it can still be given up to 5 days. And this is also, up to the clinical clinician's decision of how they want to treat this, or if it's just with supportive fluids and kind of pain relief. If it is a severe case, I'm most likely to be hospitalized. There can be more complications, as I mentioned before, leading to pneumonia, so needing oxygen therapy, or if it's severe pneumonia, maybe even being intubated and then ventilated, and then also kind of giving fluids, electrolytes, and nutritional support, just like how we do for influenza, the whole group of A and B. For PPE that we handle with these patients, we want our gloves, our gowns, and our masks, and our N95. CDC is still recommending negative pressure rooms, so that airborne contact isolation, and making sure specifically in these rooms, if you're doing any type of aerosol generating procedure, so if you have to intubate, or if you're doing a bronchoscopy or any type of procedure with the airway, that everyone has their N95 and wearing eye protection. For patient transport, you'll usually follow your same influenza protocol, just like any other type of respiratory illness, making sure whatever your facility states, and that this is a notifiable condition. So if it is an H5N1, that you are notifying Department of Health, and then you are cleaning with a list Q type of EPA cleaning criteria. So we have seen H5N1 over the years and within different countries. You can see we've had cases periodically, and then also globally. You can see that it's been in many countries over the time, but here in the United States, we just kind of started seeing this in 2024. But it has been around and presenting in other states over time. So here in the United States, most of the cases have we've had 70 cases, and you can see the breakdown specifically here in the different regions. And then to look at Texas specifically, we've just had one case. If you saw earlier this year, the one mortality case of that 70 that has happened in the United States was in Louisiana, and the individual did have other conditions that affected their overall health. and biggest risks factors for exposure to this pathogen is really being infected through environmental exposure with coming in with infected birds, cattle, any type of infected animal. Other additional factors are always comorbidities, age, and you're most likely to get infected or exposed due to occupational exposure. So looking at, highest incidence of exposure in fields of farming, animal health, veterinarian, food processing, laboratory, and public health responders. So making sure that if you have patients with flu-like symptoms that are coming in, and then, maybe asking some of those occupational epi exposure questions of where do you work? Do you come in contact with livestock? And if they say yes, have you come into contact with any sick or deceased livestock recently? And then kind of thinking, maybe this could be H5N1 instead of just another type of variant of the influenza A or influenza B. And as another, going back to just kind of the One Health, this type of pathogen is the very much of an intersect between the environmental health, our animal health, and our human health. So looking at how we're getting exposed is through our environments that we're working in, or if we have chicken or livestock in our backyards, then getting in contact with ill or deceased animals and having kind of spill over to us. And these are some lovely graphics from the CDC that kind of talks about the risk and how you become infected with when you've come into contact with livestock and their different types of feces and how they're carrying the pathogen, or consuming raw milk and handling different unprocessed dairy products can lead to certain exposures too. So these are some great handouts from the CDC. And then here's just another one looking at, working with cattle, making sure that we are aware when we are handling cattle, of being kind of mindful of what we're doing, and then practicing good hand hygiene, not touching our face, eyes, any mucosal membranes, and making sure that we're aware of what type of risk our environments and our jobs have to do and how they can potentially make us sick. So the basic level of prevention is to wear PPE, especially when you're in contact with sick or dead birds, along with practicing great hand hygiene, and then making sure that you're cooking your food to the appropriate temperature. If you're concerned about any sickness within the flocks, that you're restricting them, you're separating them, and you're kind of containing the infection so that it does not spread throughout the flock. And then you're disinfecting the equipment regularly. And then that for public health and travelers, that you're avoiding exposure in regions that you're not touching a lot of the livestock or the poultry, and then that you're kind of just aware. And currently there's no general public vaccine for H5N1 specifically. So I know that was a lot of information, and now we're going to go into the learning check, which I'll have you scan the QR code. We'll do a quick 10-question multiple choice learning activity, and then I'll open it up for questions. So I'll give you a couple seconds to scan the QR code. Okay. All right. Question 1. And feel free to put the answer in the chat. What is the primary reservoir for Marburg virus? Is it A, your Aedes aegypti mosquitoes? Is it B, your Egyptian fruit bats? Is it C, domestic dogs? Or D, camels? Great. Yes, the correct answer is B. Question 2. What is the recommended patient placement for suspected Marburg virus? Is it cohorting patient? Is it negative pressure with door open? Is it a single patient room with door closed? Or D, no specific placement is needed? So what is recommended when we're dealing with this highly pathogenic virus? Great, yes. The correct answer is C, single patient room with door closed, and also negative pressure within that room. Question 3. What diagnostic method is considered the gold standard when testing for this? Is it A, ELISA? Is it your antigen? Is it C, your PCR? Or D, rapid flu test? Great. Yes, it's C, your PCR. Question 4. Which of the following is not a recommended practice for Marburg virus? Is it A, use of double gloves, B, cohorting multiple patients, C, using EPA list L disinfectants, or D, limiting patient transport? What is not a recommended practice? Yes, it's B, cohorting patients. Because of all the highly transmissional pathogen of this, and with all the body fluids that could potentially be excreted from the individual, especially there's internal and external hemorrhaging with this, you do not want to cohort patients because there is higher risk of transmitting from patient to patient in that area. So you want those single patient rooms for these. Question 5, which of the following is a characteristic of the severe dengue? Is it A? Is it B? Is it C? Or is it D? For the severe infections, what's likely to happen or that we're concerned about? Great. Yes, it's C, plasma leakage for the severe dengue. Question 6, what is the incubation period for the virus after a mosquito bite? Is it A, 1 to 3 days, B, 4 to 10 days, C, 14 to 21 days, or D, 24 hours? So what's the incubation period? Great, it's B, 4 to 10 days. Question 7, which of the following is true about the vaccine? It's A, recommended for all individuals over 6 years of age. B, can be given without serological testing. C, is only for those previously infected. Or D, it's also effective against Zika. Great. Yes, the answer is C, for those only previously infected. Question 8. How is H5N1 most commonly transmitted to humans? Is it A, inhalation of aerosol from infected pigs, B, ingestion of contaminated water, C, direct contact with infected birds or contaminated environments, or D, casual contact with infected humans? So how do we most likely not transmit, but become infected with this specific pathogen? Great. It's C, direct contact with infected birds or contaminated environments. Question 9. What PPE is required for healthcare workers treating H5N1 during aerosolizing procedures? Is it a surgical mask? A. Is it gloves and face shield? B. Is it C, an N95 or higher respirator? Or D, no respiratory precautions are needed during AGPs. Great. Yes, the answer is C, at 95 or higher respiratory. And then lastly, for question 10, what is the first line treatment for symptomatic H5N1 infection? Is it A? Is it B? Is it C? Or is it D? Great. Yes, the answer is B. We want to be giving Tamiflu to these patients. Again, it is up to the clinician or the primary care individual who's overseeing the patient of what type of treatment that they would likely have, but these ones have shown to be effective. And so here are the answers for the learning activity. Okay. And then to kind of wrap up this lecture before we go into the question part in any type of discussion is that really looking at emerging infections, we're starting to see a global trend of them. Over the last couple of years, we've seen Marburg, we've had the COVID, before that was Ebola. So we're starting to see more type of emerging infections. We've seen measles and these very highly transmissible infections. So making sure that we have good IPC foundations of making sure that we know what PPE to wear, how to clean our hands, what type of EPA or hospital grade disinfectants we need to be using on the patients, on the equipment, what's effective, how to classify our waste, if it's A waste, B waste. Really helps us impact and prepare for these types of emerging infections of, how do we respond to them? What is it going to look at our organization? How can we better be prepared? So kind of understanding of what's kind of going on, not only just locally within our community and statewide, but globally, nationally and globally, we can kind of help know what new pathogens other states are starting to see, other areas are starting to see that maybe we should review our policy on that specific pathogen, or maybe create a policy, procedure, or protocol to deal with that pathogen at your facility, and just kind of bring awareness of that. We're starting to see these more atypical pathogens. So when you're having a patient present, do your standard rule out of within common practice, but thinking some of these other pathogens, for respiratory, flu-like symptoms, you can have West Nile, you could have Zika, you could have malaria, you could have chikungunya, you can have dengue. They all kind of present with flu-like symptoms. So if you're first doing, your COVID, influenza A, influenza B, and RSV panel, and nothing shows positive on that, maybe then expanding in for other types of pathogens that might help you identify with that. And then also if, as I mentioned, the rapid point of care combination doesn't really stereotype, or it does not stereotype what type of strain of influenza that you have. So if you're positive on influenza A, maybe then thinking if they're more symptomatic, asking or requesting for more of a serology or genomics on, is this the H5N1 type of it? So just kind of being aware and then educating your individuals of symptom presentation and just kind of your clinical partners of, we are starting to see this could be, it could be in the community, it's within the United States. These are maybe something that we should expand in thinking of if nothing else is going positive. And then making sure that we know how to identify them. We have a plan. Anytime we have rapid identification, we can go to containment to reduce spread, and really having a strong, robust training on infection prevention and control practices really helps ensure safety for our patients and healthcare providers, especially when they come into contact with emerging and highly pathogenic new sorts of pathogens. So I invite all of you to connect with us. You can email us directly if you have questions, concerns. You can email us directly at ipc@tefi.texas.gov. Here's a QR code to look at the other types of different groups that have Tefi offers of different type of training and education and seminars, along with our social media connections. One announcement before I open it up for questions is that we are having the Tefi Summit. This is an annual summit we hold each year. It is open to the public. It's free. It's a hybrid event. You can come in person or online. Here is a QR code and registration is open. It is on Thursday, September 25th from 8 a.m. till 4 p.m. The list of the agenda is on the website. So if you want to see who's talking in what areas, definitely check that out. And then something that we're starting to pilot is last month we held the first IPC office hours. This is an informal space. It's going to be an hour long. Our next one will be next Thursday on September 11th from 2 to 3 p.m. Central Standard Time. And this is an informal, unrecorded session. It doesn't provide any continuing education. There will not be anything presenting for a learning activity, but this is kind of an area for IPCs to network and connect throughout the state of Texas. Other states are welcome to join if they want, but we're really going to be talking about things going on in Texas, kind of share our challenges, what's working well, what's not working well, collaborate, and kind of learn from it. So this will be a discussion, kind of an open, informal. The expectation is to be courteous and professional. This will be discussion, so you will be able to talk throughout it. And then any type of disrupting behaviors will remove from the session. And if you would like the invite, if you have not received it, please email ipc@tefi.texas.gov. I am more than happy to forward you the invite for the upcoming session. And then lastly, our next module will be in October, titled Outbreak Investigation. And this module will be co-presented with the Texas Healthcare Associated Infection EPI team from the Department of Health from Texas. So we're doing a joint presentation and we're going to talk about outbreak investigations, first on the acute care side, and then kind of how DSHS goes into the responsibility at the facility and what they kind of do during the outbreak. And then also different things that we can do in the long-term and care facility, and then also talk about our interfacility communication and transport form that we have here in Texas. I ask you to please complete the post-module survey. The QR code is here. If you complete it, you will be eligible to be mailed Tefi merchandise. And those that have wanted to see what previous lectures Tefi IPC has done, these two papers are from our first year, our 2023, and our 2024 lecture series of what's there and the data for the surveys that we have you guys complete. And then lastly, this is the instructions for how to obtain continuing education hours. So you'll build your profile, follow these steps. And to get your certificates, again, today's lecture is recorded. Within approximately a week or so, you will get access to the recording along with the slides. So with that, now I'm going to stop sharing and kind of open it up for any questions that anyone has. Any questions so far? So for the I see one question for the survivors of Marburg. Are they immune for a later infection? That's a good question. I do not know. I haven't seen any data on that. I think usually this is kind of a one-time exposure infection, but I haven't seen any data really talking about secondary infections or that they've been infected multiple times. But that's an excellent question. Yes, to the question about in the email, you'll get the slide deck so that you'll be able to scan the QR codes along with the links to the different learning activities, how to obtain the CEs. That will all be in the slide deck that you should receive within a week or so of the presentation. For the question, so with COVID-19 versus Marburg, that's a good question. I don't know if the same dosing schedule. I think it would kind of depend on patient presentation. It is investigational, so there hasn't been a ton of data on it. But I would kind of leave that up to how the patient was presenting, and then also what the primary clinician and kind of what the pharmacist also says and recommends for them. Since with COVID, it's more respiratory, I'm not quite sure what the chemistries of depending on how much blood loss and their electrolyte balance. So making sure that we don't have a kidney injury with these patients since they are losing a lot of fluids and bloods, if the dosing would be the same. But that's an excellent question. So I would kind of defer to your ID physician that's seeing the patient, along with asking your pharmacist what they think about that, along with all the other medication supporting fluids that they're getting. So why are negative pressure rooms prescribed? So think with as I mentioned in the lecture, there hasn't been historical aerosolized transmission for that. But however, because of all the fluids here in the United States, we always want to up level, or the CDC usually up levels the type of containment that is needed. So just because there is not airborne transmission, they want them in a negative pressure room. With aerosolized generating procedures, there is always an increased risk of exposure because you are usually during aerosolized generating procedures, you are standing close to the patient's airway. You're either intubating them, or doing other type of manipulation. Because there is an increased risk to the healthcare provider, that's why they want the N95. And because there's also a risk of this, and we want to make sure that we are, during these types of procedures, that we are not just disseminating these airborne particulates in the environment. That's why they want them in a negative room. Usually because these patients are so critical and there is a lot of things go on with them, and there's going to be a lot of people in the room to handle this patient, and they're going to be very critical. They're going to be very sick. They're going to decompress very quickly. It's better to have it all set up in a negative pressure room. There is an extra level of control because of the negative pressure with the air exchange, that there's not going to be exposure to other healthcare individuals and less likely transmission. So it's an extra level of safety, especially historically during the outbreaks that we have seen more of the fatality for the healthcare providers compared to patients. So that's another wise that to protect our healthcare providers, they're upping it into negative pressure. And then especially if you're doing aerosolized generating procedures, you want to be in that negative pressure wearing N95s and all the protection. Does that make sense? And then the next one, there's been higher survival rates for Ebola patients carried by family members at local clinics. Is this true for Marburg? I have not seen that data. I have seen that in some countries, they're showing better care and outcomes for it. But I haven't seen that data. I think we've also seen less patients with overall globally with Marburg over Ebola. Um, so I'm not sure, but that's an excellent question. It would be interested to do a comparative since they both are viral hemorrhagic viruses, that to see if there's a difference in care from family members. Well, thank you all. If there's no more questions, I thank you all for participating. I hope to either see you at the TEFI office hours or future TEFI events. Please let us know if you have any questions. Please take the surveys. That really helps us know what topics to present to you, what you guys are needing and what you're getting from these lectures. So I just want to say thank you, and I hope you all have a great day.